Okay, now on to pancreatic pathology. First, the function of the pancreas. What is the exocrine function of the pancreas? It is to secrete enzymes for the digestion of fats, proteins, and carbohydrates, all the nutrients that you can take. Now, the pancreas also has endocrine function. We haven't really talked about that because we're saving that for the endocrine section. But the pancreas will secrete hormones like insulin. Okay, so now let's talk about pathology. The first one is acute pancreatitis. So again, itis, inflammation of the pancreas, and it arises from autodigestion by pancreatic enzymes that are prematurely activated. So note that this is not a bacterial infection, okay? This is from autodigestion by pancreatic enzymes. So it's pretty much digesting itself, unfortunately. Now, the most common causes of this autodigestion are from alcohol and gallstones. There are many other causes, including hypertriglyceridemia. You can look them up in first aid or online for nice mnemonic. But the two most common causes are alcohol and gallstones, and this is what the gallstone cause. So what's going to happen is alcohol, but basically all etiologies lead to a pancreatic cell injury. It can be through direct toxic damage, as you see in alcohol, or from ischemia from obstruction, as you see from the gallstone. Okay. Now, this pancreatic cell injury is going to lead to premature activation of trypsinogen. Normally, trypsinogen is activated over here in the small intestine. Remember, what does trypsinogen do? What does trypsin do? Activated trypsin. Trypsin is going to activate the other pancreatic enzymes. Normally, it activates it here in the small intestine where you want them to be activated. But in this case, pancreatic cell injury leads to premature activation to trypsin. Trypsin is then going to go and activate all the other pancreatic proenzymes that are hanging out in this pancreas. And then they're going to digest the pancreas. You're going to have proteases digesting the pancreas. You're going to have elastases digesting the blood vessels. That's going to cause bleeding. And then you're going to have digestion of pancreatic fat from the lipases that are activated. So you get fat necrosis, okay? So premature activation of trypsin thanks to pancreatic cell injury, most commonly from what? From alcohol and gallstones, causes destruction of the pancreas, causes hemorrhage and bleeding, and causes pancreatic fat necrosis. So, clinical features here are you're going to have pain, and where you're going to have pain, it's going to be an epigastric area. So, pretty much upper abdomen, right below where your ribs are in the middle. And it's going to be radiating to the back. And you're going to see that in all our pancreatic problems, okay? Epigastric back pain, abdominal pain radiating to the back. You're going to have at least one of the following things to diagnose this. You can have elevated serum lipase or amylase. And these are enzymes that are secreted from the pancreas, and which one is more specific to the pancreas? When I'm asking you that question, I'm basically saying which one is found in less of other tissues. The answer is going to be lipase, because remember we have amylase in our salivary glands. So amylase can be elevated in parotid gland problems, but lipase will not be. So lipase is more specific for pancreatic damage. And that's something key to know. The other thing you can have is some characteristic pancreatitis imaging findings. It's a little bit too high, next level for step 1. Now, complications from this pancreatitis, for this inflammation, are you can have a pancreatic pseudocyst, which I've depicted in this picture. And this is basically a pseudocyst, and it's a fibrous granulation tissue covering it, okay? And it's basically all this pancreatic fluid. The next thing you can have is a pancreatic abscess. So it's a walled off infected necrotic tissue and all that pus. It's walled off, so that can be a complication. And both of these can cause pain. So this fat cyst / abscess on the pancreas can cause inflammation. It's going to cause irritation. It's going to be pressing on surrounding organs. It's going to cause pain. The other thing you can have is you can have shock. Remember I told you these pancreatic enzymes can lead to breakdown of your blood vessels thanks to elastase. You're going to get bleeding and you can get shock. And finally, this is a throwback to the pulmonary lectures, you can get ARDS, acute respiratory distress syndrome. And this happens because the pancreatic enzymes are going to get into the bloodstream and they're going to flow around and they're going to reach the lungs and they're going to cause inflammation and diffuse alveolar damage. And that was the key word for ARDS, diffuse alveolar damage. Okay, so now we're going to go to chronic pancreatitis. That was acute pancreatitis. Chronic pancreatitis arises from chronic inflammation of the pancreas. And that chronic inflammation is going to lead to fibrosis and failure of pancreatic function. So it's very similar. It's kind of very parallel to the liver problem, where you can have acute liver failure and you can have cirrhosis, which is chronic liver failure leading to fibrosis and failure of the organ function. Now, this most commonly occurs due to either chronic alcohol abuse in adults or cystic fibrosis in children. So chronic alcohol abuse leads to direct toxic damage to the pancreas. And cystic fibrosis, what happens is you get these you get really thick mucus plugs, you get pancreatic duct obstruction, and then you can get subsequent loss of acinar cells and fibrosis. Okay. Now, what were the clinical symptoms here? Remember, I told you all these pancreatic problems, what is the pain? It's epigastric abdominal pain that radiates to the back. And then just like how I told you how cirrhosis is, this is parallel to cirrhosis. Cirrhosis is loss of liver function. This will present with loss of pancreatic function. So what was pancreatic function? I told you pancreatic function was to secrete digestive enzymes, including enzymes to help break down fat, so like lipases. So you're not going to break down fat. We talked about that. You get steatorrhea and you get deficiency of fat-soluble vitamins A, D, E, K. Now, what was the endocrine function of the pancreas? Endocrine function was to secrete insulin, and if you have chronic pancreatitis with pancreatic insufficiency, that's not going to happen. So you're going to get diabetes mellitus due to lack of insulin. Finally, I want to note that amylase and lipase levels are not as useful here because they may or may not be elevated. Because eventually, if your pancreas function is too low, you're not even going to be making amylase or lipase. Your amylase levels and your lipase levels are going to be low, and maybe it's possible. Okay, so that is chronic pancreatitis. Really, just very similar, very parallel to the chronic liver failure, which is aka cirrhosis. Now, finally, we're going to talk about pancreatic carcinoma. This is a very aggressive tumor, and it arises from the exocrine pancreatic ducts. So that's the ducts where the enzymes are released, and so this is opposed to, this is not from the endocrine pancreatic islets. Now, this is a very poor prognosis, partly because many times it has already metastasized the presentation. Okay, very, very poor prognosis. Now, the risk factors here are very common. So smoking doubles the risk, diabetes mellitus, chronic pancreatitis, so inflammation causing problems, and then you can have genetic syndrome, so MEN syndrome. This is the Lynch syndrome, or the familial adenomatous polyposis. Remember, those were the colorectal cancer syndromes. So, clinical features. What were the clinical features of chronic pancreatic carcinoma? I already told you two of them. When I told you pancreatic problems always have epigastric abdominal pain radiating to the back. And then what was the other one I told you about? It was similar to the gallbladder carcinoma. Remember I told you that obstruction of bile flow from cancer can lead to something called the Corvier's sign. And that sign, what was that sign? It was jaundice with a non-tender palpable gallbladder. Okay, that tells you there's something obstructing these bile ducts. There's a tumor obstructing these bile ducts. Either it's a gallbladder tumor obstructing the ducts here, or it's a pancreatic tumor at the head of the pancreas. Head of the pancreas is this side, and it's going to block the pancreatic duct, and you're going to have blockage of bile flow, and you get this Courvoisier sign. Finally, you can have migratory thrombophlebitis. What this is recurring thrombophlebitis. Thrombophlebitis means inflammation of a superficial vein due to blood clots. Okay, blood clots, and remember, cancer is a very hypercoagulable state, so you get these mini blood clots in these superficial veins, and it's going to cause inflammation, and it's going to be recurring and be in different locations, hence the migratory. Okay, so these little blood clots basically presents like a mini DVT. How does DVT present? Inflammation, swelling, erythema, tenderness. Okay, that's migratory thrombophlebitis. So now you know migratory thrombophlebitis, Courvoisier sign with obstructive jaundice, and epigastric abdominal pain are all characteristic of pancreatic cancer. Finally, the treatment here. Again, this is very poor prognosis treatment. The only really good method for cure we have is surgical resection. If you can but even if you do a good resection, get most of the tumor out, there's very poor prognosis. Even when you have a nice surgical resection, prognosis is still poor. Okay, and the way you do this is through the Whipple procedure. Okay, what you're going to do is you're going to remove everything that I've highlighted in the red. This includes the gallbladder here. This includes part of the duodenum here. It includes the head of the pancreas. Okay, so that's the Whipple procedure. Head and neck of the pancreas. the duodenum, and the gallbladder, all removed in the Whipple procedure for pancreatic cancer. So that's it for our pancreatic pathology.